oral environment.
You're being recorded, Matt.
Okay. And so hopefully tonight I can show you a few of those things. Like, I really want you to be like, oh my gosh, I never knew that before. I've never heard this before. Because I think what it will do is the biggest thing is it opens your mind up as an educator to your patients. And that's definitely what it's this journey has done for me. Is I feel like a lot of the discussions before that I was kind of just left not knowing what to say or how to direct my patients. Now it's led to a discussion and a discussion that the patient starts to understand as well. So let me see if I know how to do this.
Well, let's address the elephant in the room, Matt. To you guys, yes, his arms really are that big. It's not the camera's not distorting anything.
No, it is the camera.
The fibers on that shirt are literally just barely hanging on. There, it's probably a stretchy shirt.
If I use
so Dan, this isn't giving me the option. Oh, there we go. Share screen.
If I use
it says that
will it look like that?
Dan, it says that you're not letting me share my screen.
That's me. Try that.
Okay, let's see. Select.
There we go. I can see it now.
Yeah, see it.
Okay. So let's go like this. Okay. And then, okay. So I'm going to go through a lot of this because I know, again, a lot of the times we're giving presentations to offices and hygienists. I realize that you guys have been down a lot of this. I mean, our journey kind of started in dental school as well. So again, just briefly, we'll discuss, again, kind of like Dan phrased it, the elephant in the room, some of the hurdles, and then what our solution was that we came up with. The biggest thing that's interesting when you start looking into hygiene products is they really haven't changed in about 100 years. If any of you golf, like, I couldn't imagine using a driver from 100 years ago, but yet somehow in dentistry, we're okay with the dogmatic, view of let's hold on to these things because we were using them 50 years ago. It wasn't until we started looking at hygiene products from a problem solution point of view where we started to see that. So if we look at it, fluoride sealants, we realize lots of studies that show their efficacy, show what they do, what they don't do. I realize there's a lot of arguments, polarization, dose dependency, blah, blah, blah. We'll skip over that. This is primarily what we've been using. But what we do know, if we look at the data, so data over dogma, is that 92% of people are still getting decay. And the realization is, if you have someone with decay, they're also most likely, there's definitely an encouragement or an insult to other dental disease as well. Whether it's something as simple as gingivitis, you're going to see that. It may be something like autoimmune, like cankers or whatever, but sticking to caries for this presentation, we know the data shows us 92% of people are still getting data. Now that comes from when you look at the father of dentistry, who basically believed that someday we would have a way to preventatively deal with dentistry rather than what we do now with the mechanical reparative. Now, okay, so what's the core problem? We already know what it is. We've been taught it, right? It's acid. You get a pH of 5.5 in the mouth, boom, all dental disease. There almost isn't a dental disease that you can find in the mouth that isn't related in some way to a low pH. We know, we're taught it. The number we're given is 5.5. This is where the core of most dental disease will start. Now, you may argue and say, well, gingivitis, periodontitis, with plaque and calculus. But what happens is those plaque and calculus ultimately leads to a lower pH, which starts the inflammatory processes. So we know that acid is the problem. In fact, we've actually even we see it here where that same strep mutans is selective for pH. So when we start to talk about the biofilm in the mouth, the one thing we don't want to do and the one thing we can't do is you're not going to get rid of it. It's a living thing in your mouth. You brush it off, you try and brush it off, it's back within 2 minutes. And we're going to talk about that a little bit more in just a second. But what we do know is the bacteria are selected for. So in a healthy 6.8 to 7.2 range, you're going to have your probiotic bacteria. Strep mutans at 6.8 to 7.2 is not unhealthy. It's not over aggregating. It's not actively reducing lactic acid. It actually has there are some controls and balances with other pathogenic bacteria that it provides. So you want some of it. You don't want an overgrowth of it. But we do know if that pH drops in that biofilm and you start to get an overgrowth, you start to get an overaggregation of it, it's going to start to produce lactic acid and you're going to start to have problems. So this is undeniable in the science. We know the bacteria is pH dependent. The other proof to this concept is the Stefan curve. I don't know if a day goes by where I don't talk about the Stefan curve with a patient. Every time you eat, every time you drink, you're going to encourage a drop in that biofilm pH. We're not talking about salivary pH. We're talking about the actual biofilm that's coating the surface, the bacteria that are linked together with the exopolysaccharide structure. Within that biofilm, there is a pH. You eat, you introduce that glucose feeding to it, it's going to drop, and then it takes your saliva sometimes hours to basically re-neutralize that acid attack. And this is why for people that are challenged with recurrent decay, that's why we tell them it's better to eat when you eat, drink when you drink, and nothing but water in between. Because if you have a person who's sipping on, coffee or soda or snacking throughout the day, it never gives their body the ability to re-neutralize that acid attack. And so it can be super, super destructive. So when we know that pH is the core of the problem, and then we start looking at our hygiene products, this was the first thing that we were kind of like, wait a minute, something seems off. And it's when we first said, okay, we're going to solve this. And we started looking for products. And at first we were thinking, we just need to find alkalizing products. What we found was on the market, 99% of the products that you'll find are actually acidic and relatively acidic, in the point of they're below that 5.5, that critical zone that can actually interfere with remineralization. They can interfere with healing. They can interfere with inflammation. Now, do these products disrupt the biofilm or disrupt the bacteria? Yes, but they do so at a cost, and it's called rebound. And this happens with chlorhexidine. It's one of the reasons, and we'll get into it a little bit more, but one of the reasons why chlorhexidine is only good for a couple of weeks is because chlorhexidine will reduce strep mutans. You're going to get a very, very aggressive rebound because of the pH environment that it's producing. So, one, we know the state of hygiene, again, like we said before, it's a 100-year-old system of trying to use an acid-based product to solve an acid-based problem. Okay, so the biofilm. This undeniably is probably the most misunderstood concept in dentistry. We talk about it all the time. We kind of we'll group it into either plaque or bacteria, but it's a lot more complicated than that. And neutralizing within the biofilm isn't as simple as people think. I once had another doctor tell me that all he had to do is give his patient a litmus tab or have him rinse with baking soda, and it would neutralize the biofilm. What he didn't realize is there was a difference between salivary plaque, biofilm plaque. Getting inside that biofilm, you can rinse and swish and whatever, you can brush. an interesting point I'll just bring up right now is you can have two, say, mouth rinses, toothpaste, it doesn't matter. You can have two identical products that have the same active ingredients and they will perform completely different based on the surface charge of the biofilm. Now, this is something that maybe you've heard about before. We'll get into it a little bit, but the biofilm, in relation to it, has it's called the Stern layer theory. So there is a charge to this biofilm. So you can have two products that are identical in active ingredients. The way they are formulated, one will get in and one won't. And this is kind of how our saliva works, right? We have a hierarchy, we have enzymes that will basically are charge related that can get through the biofilm to help deliver calcium inside to then start to neutralize those acid attacks. So that's the one point I want to bring up right here is in regards to this biofilm, it's not just this sticky pellicle that sticks onto the tooth. It is an electrical defense. You have an invisible electrostatic force field of ions that surround this bacterial field. It attracts basically positively charged ions like calcium, and they help stabilize the structure. But this is the reason why, so not just the biofilm, but the charge of the biofilm is the reason why 99% of the products that you see out there, they're not formulated to deal with the charge. They're not formulated from a chemistry in mind. They're just a lot of them. I mean, when you look at the ingredient deck, they just throw in some essential oils for flavoring. They might throw in a couple things because they heard it was good for your teeth. And they kind of just mix it all together and hope that it sounds good in a marketing ad. But even if you look at fluoride, and this is in all the debate that's going on with fluoride right now, fluoride is a very weak biofilm penetrant. And so not only because of the charge, but because of the pellicle formation. So you have 1,000 ppm is your baseline clinically significant dose that you have to have for fluoride to where it shows any type of calcium replacement with a fluoride ion. With a biofilm, at 1,000 ppm, you're actually only getting 60 ppm. It has 2 to 6% penetration rate. So it's super, super, super weak. So a lot of the arguments on topical fluoride, right? Topical fluoride on a daily basis. If you're using 1,000 ppm fluoridated toothpaste and fluoridated rinse, and you're using it on a daily basis, you're really only getting about 60 ppm, which is clinically insignificant. And that's why the varnishes will actually show higher efficacy because you're at 25,000 ppm. So even with the biofilm, you're getting a lot stronger or a lot heavier dose to the tooth structure. But the biofilm is basically this thick fortress wall that is not easy to get through, and it's not easy to neutralize. This is kind of like just a graphic of what you show the tooth enamel, and then you show this thick exopolysaccharide matrix that links the bacteria together. And again, it's not just a fortress wall. There's on top of this, and I'll show you a graph in a second, there is an electrical charge that surrounds this thing that if you're the wrong charge, it's just not going to, one, adhere to it, and two, it's definitely not going to get through it. So if we look at a few of the biofilm penetrants that are common in hygiene, iodine, chlorhexidine, hextidine, CPC, which is cetiopyridium chloride, and thymol. Thymol is what you'll find in Listerine. These are your most common. In order for them to show any type of bacterial disruption and or biofilm penetration, these are the doses you have to have them at. So you look at chlorhexidine is 1,200 parts per million. Iodine, obviously, the biggest at 10,000 parts per million. But the interesting thing here is now if you look at nano-silver over on the far right, it only takes 15 parts per million. That is like nothing. It's such a small amount, and yet at that small amount, it shows similar efficacy to chlorhexidine. So at 80th, 80 times less of the amount needed for nano-silver to show the same type of antimicrobial and antibacterial action as chlorhexidine does. So this just kind of shows the doses. Now, again, back to that chlorhexidine, because this is an interesting discussion because we use it or has been used very commonly, whether it's a post-op protocol, a post-perio protocol. And the interesting thing about chlorhexidine is it has actually shown in studies to be a very persistent reducer of strep mutans. But in the same sentence, it doesn't show a reduction in caries. And the reason why that is comes down to that electrochemical, that charge layer that we talked about, is chlorhexidine, because of the charge, it interferes with the remineralization potential. So it will literally prevent the remineralization of your tooth structure. The other thing that happens with it is you get that I mentioned previously, you get a rebound because of the pH. And that's the interesting thing about the biofilm and the Stern layer theory, that charge layer that we talked about, that we'll probably say it 100 times, but it is pH. Those are pH dependent as well. You change the pH and you can change that electrochemistry as well. So chlorhexidine, here it is. It's a strong reducer of strep mutans. It doesn't prevent caries because it interferes with remineralization. In addition to other things, we know that because of the pH, it can actually interfere with healing and fibroblast formation. And those are some of the other hot topics that we have in regards to chlorhexidine. Okay,
Matt,
real
quick, Matt, would you mind speaking to that a little? That's been an interesting topic about chlorhexidine. And I know you're not this presentation isn't about chlorhexidine, but I think it is discussing and diving into a little bit because, I know when you and I were at school together, man, all the surgeons, our protocol was chlorhexidine based post-surgical, right? And then in the Air Force, we handed out chlorhexidine post-surgery, with every third patient we had or implant patient that we had. Can you kind of delve into the science a little bit more on why there's inhibited and delayed wound healing with chlorhexidine?
So that's, again, if I can blow up this little chart, I don't know how well you can see it, but it literally comes back to those two things, the charge of it and then the pH of it. Because of the pH, chlorhexidine basically disrupts you get that rebound effect of the pathogenic bacteria. There's actually a class action lawsuit right now against Listerine for the same thing, that daily usage of Listerine will actually encourage pathogenic bacteria. So chlorhexidine, it works like if you want to use it as like a pre-op rinse to just kind of kill everything, that's fine. It's when you start using it in that repetitious where it starts to disrupt the biofilm, but it's disrupting the biofilm by lowering the pH. So you get that rebound of that encouragement of pathogenic bacteria. But also because of the charge, it interferes with the calcium uptake. We've actually found, and I've got a slide later that I'll show you. And actually this month in Compendium actually talks about using it wasn't our product specifically that they were mentioning, but it talked about using a nano-silver with a post-op for implants, because of the charge and because of the pH stabilization that it does, it actually encouraged bone growth around implants. So kind of an interesting thing. We know with chlorhexidine too, the staining problems that people have with it, right? The fibroblast, it inhibits fibroblast formation, which is like a diabetic does. Uncontrolled diabetics have a hard time regulating fibroblast formation. It puts them in that ability to where they don't wound heal very well. That's another issue with it. So I hope that answers some of your other questions, but.
No, that was perfect.
Okay, so ZPC, this is a study. It gets into the first part of that stern layer theory. In order for a tooth to, what this study basically showed was that there is a 0 point of charge potential on the surface of enamel, where enamel will either hold on to calcium or it will release calcium. And what we found is that process of remineralization, the process of demineralization is pH dependent. So when you get a healthy pH of 6.8 to 7.2, because of the charge potential that's related to it, enamel will not demineralize ever. It cannot. It's impossible, would be virtually impossible to get a cavity if you kept the pH around enamel at 7 to 7.2. Because of that, again, it's like a fortress. It's not going to let go and release of that calcium. They've actually even shown this stern layer is so strong that there's the analogy of brushing your teeth. Trying to brush off your biofilm is like trying to pressure wash a castle with a garden hose. Like, so we think that by brushing our teeth, we're getting mechanical removal of the biofilm. You're not. You're getting mechanical removal of excess plaque. But that biofilm is, again, you've got this electrochemical adherence to the tooth structure. So this was probably one of the most significant studies that we found, is when we started realizing that health, oral health, remineralization, demineralization is actually, it's more related to chemistry than it's related to biology. Okay, here's the slide kind of I talked about. This is the second part of the equation of this biofilm, which is the stern layer. And there's a few important points I put down here. One, once you drop, what happens is when you drop, you can see, I don't know how well you can see this, but right at the tooth surface, enamel is positively charged. You have this positively charged stern layer, is what it's called. Then on top of that, you have this negatively charged diffuse layer. And that's why, depending on if something's, the charge of it will depend on whether it's able to even get to the enamel surface. When the pH drops, what happens is it floods that stern layer with hydrogen ions, and that kicks out the calcium. So that's what starts that demineralization. Beyond the stern layer, you have enamel that's negatively charged. And this is what makes the hydroxyapatite discussion really interesting, because hydroxyapatite has been basically pitched as a fluoride replacement, right? Enamel's negatively charged. Hydroxyapatite is negatively charged. We know that because of the charges, they're not going to attract. In fact, a lot of the chemistry data behind hydroxyapatite shows that where you can mechanically like fill a void, you're not going to get a permanent bond. So people will basically feel like they're getting some sensitivity reduction, but what you're going to get what's called a washout after the fact, because there's actually no cellular assisted mechanism for hydroxyapatite to bond back to the tooth surface. And actually, if you think about it, enamel is calcium phosphate bonded structure. Hydroxyapatite is calcium phosphate pre-bonded structure. So the bonding has already taken place. And then on top of that, to get this charge, you're going to get more of a repellent type action, and it's not going to bond to the tooth structure. Third point, remineralization relies on ion exchange, which we've already kind of talked about. Another point that I thought was interesting was demineralized sites are like really, really positively charged due to the loss of the phosphate. And that's why strep mutans are so attracted to them, is because they're negatively charged. So in a demin site, you start to get that porous tooth structure. And the reason why the strep mutans are so aggressive compared to other bacteria is because of their charge. And so again, what we're really trying to paint here is you can see that there's this chemistry opponent to oral health, to remineralization, to demineralization that has never been addressed before in this way. Okay, so now if we go back to those biofilm penetrants, same ones we looked at before, and now we look, okay, not only does it take super, super high concentrations of them to have any efficacy to be a biofilm disruptor, we also see that on the pH scale, they all fail. They fail because of their pH. And so iodine, chlorhexidine, hexidine, CPC, thymol, they're all super acidic. So again, back to the previous slides, they're going to disrupt this Stern layer theory. They're going to disrupt the model of the 0 point of charge on enamel, and they're basically going to interfere with calcium absorption and impede that attraction to the two surface. So we kind of covered a lot right there. Is there any questions?
So this,
If not,
well, I think it's worth, when Matt first started talking to me about this has been several years ago. There's really I think that this is, like I said before we started, to me, Matt, this was like, again, this was revolutionary, not evolutionary. This is something that I think it begs the question, why did it take you guys introducing this to the market to get the science rolling? Because I know you guys have had a lot of studies done, by independent studies done, and that's where you're pulling a lot of this data from. But why? Why has it been 100 years of the same thing?
Again, I think there's a couple things. I think one, it goes back, you go back to evolution. Listerine started out as a medicament for gonorrhea, right? Kind of evolved into like a household antiseptic. And then as we started to learn about the microbes in the mouth, they started to use it to disrupt those microbes in the mouth, right? So you have an evolutionary product of a product just being used and just becoming dogma, for one. Two, the other interesting thing is, so nano-silver or any other types of silvers, again, in theory, they sounded good, but when we first started testing them, they didn't work either. And the reason why is it goes back to this Stern layer. What happens is you have all these charged salts in the mouth that when ingredients start interacting with them, they just don't seem to work. What we did is we actually took that, and I'll describe it a little bit more here in a second, but we took that nano-silver and we encapsulated it in an exopolysaccharide structure. So we wanted the potential, the minimal charge potential of nano-silver, but we needed it to adhere to the biofilm. So what we did is we basically synthesize it in a biocompound, which is an exopolysaccharide, which is the same biocompound that your bacteria use to link together. So in essence, it uses a principle of biomimicry in order to adhere to the biofilm. That way we were, able to get it to deliver calcium and other ingredients to the two structure, but two, that was the only way we could actually get it to show any efficacy as well. So that's the second point. The third point is, Dan, I just think it comes back to Ryan. So my partner, Dr. Nolan, he entered dental school after having completed some very advanced coursework in chemistry. Nobody has ever looked at the mouth from a chemistry point of view. In fact, most of these points, when he was taking them to instructors, even in school, they had no clue what he was talking about. Even our karyology professor, who you would think would be the most up-to-date on the science of the mouth, he understood the science from a biological point of view, but he definitely did not understand the science from a chemistry point of view. ZPC, Stern layer theory. And so it really took, I feel like, an innovation from a hybrid of knowledge. One, Ryan understanding, him looking at some of these other products and just in his mind, he's seeing these equations and being like, that won't work, right? I mean, I've since learned from him, these were definitely things that I had no clue about even after dental school. And so I think a lot of it is that we've approached dentistry from a biological point of view, and we've never approached it from a chemistry point of view.
Well, I think too, I think we're kind of suckers for of tradition, right? Like, and not just that, but also marketing. I hate to say that, but like, how often do we look at the actual science of, the products that we use? In dental school, we did a little bit, but, I think that if I own Colgate or whatever, and I've got a product that's selling, and it's good at killing bacteria, and that's what I'm marketing it as, and we're like, oh well, strep mutans causes caries and this kills bacteria, therefore I'm making that correlation, like you said, dogma, and I'm not really using data, then we'll just continue the course. You know what I mean? And why would they stop doing it when they're selling it and making money? They're in money, so it sucks that when you first, what I was leading into is that when you first introduced this, I really felt foolish, that I was like, dang, like I'm a sucker for just doing what's been done, you know what I mean? And I'm like, oh, so this is, for me in our practice, this has really been transformative. But yeah, just I like your take on that. Appreciate that.
Okay, so just going along this slide. So basically, once we saw that, these were points that we were researching, we were finding, then we had to come, okay, so what are we really trying to achieve here? And so when you look at it from a chemistry, that electrochemistry point of view, one, you have to increase the pH value of the biofilm, and you have to do it in a short period of time, because the longer you wait, the more demineralization, the more calcium extract you're getting to buffer that acidic solution, the more damage to the tooth. In order to do that, you have to break apart the biofilm. We know after seeing that, again, it is a fortress. It is not only a physical exopolysaccharide, fortress, but it's an electrochemical shield. That's not easy. Once you've done that, it's imperative. The only way you're going to get repair in a tooth is to increase the calcium ion activity at that tooth surface. Because of the charge, the tooth is going to, if the pH is right, the tooth is going to suck up calcium like a sponge. Again, and I'll show you the study here in a second. The study we did where we compared, again, this model of using a encapsulated nano-silver to break the biofilm, to get to the tooth structure and deliver calcium, we had almost a 700% increase in remineralization compared to fluoride. It's, again, I mean, I hate to say it because it does seem like a lot of science, but it's not rocket science. We know that that's what the tooth does. It's a scale at a pH of 6.8 to 7.2. It takes up calcium. That's just what it does. That's what the charge is. That's what the science makes it do. If you lower that, it's going to give off calcium, and you're going to have demineralization. So how are we going to do this? We couldn't. We tried every biofilm penetrant. We tried every alkalizing agent out there in different ways, and we couldn't get it to do it. Now, we know just by way of their physical properties of silver being, one, a biofilm disruptor, but two, an alkalizing agent. It's the only substance we know of other than the enzymes in your saliva that do that. So we started going down that road. The only problem is we had to stabilize it. There's a lot of people that will, for health purposes, will drink like colloidal silvers and even nano-silvers. The reality is you put them in the mouth, and with the oral salts, they're inactivated almost immediately. The charge potential is blown, and it's done. So we had to come up with a solution for that. So what we did, this kind of shows it here. We took the nano-silver and we encapsulated it. And this is part of our patented process to synthesize it, using a plant-based biocompound. The other thing it did is it made it very, very consistent. So we're able to produce the nano-silver that's the one thing with silvers is sometimes you get different size profiles where they'll be all over the place. We were able to produce it and have very consistent 5 to 10 nanometer size profiles. But because they're encapsulated, and I'll talk a little bit more about it, it basically prevents any type of, like, we also don't want nanoparticles just floating down into spaces that we don't want them to get into. The encapsulation process prevents that. It basically, if you swallow it, it's going to pass through your digestive system. If you put it down your sink, it's going to be filtered through water systems. It's kind of ideal. But because of that encapsulation, it uses a biological principle called biomimicry. It will adhere to and because of their charges, because they have similar like charges, it basically integrates into that exopolysaccharide structure. And then the nano-silver's potential starts to take place. It just starts to pick apart those little pathogenic bacteria that have been overgrown because of its pH. And that's the most significant thing about this, is it's not a lysolic effect or a Listerine type effect where it just wipes everything out and you get a rebound. It's almost just like, it's just picking apart, regulating, creating an environment where you're going to get the commensal, the healthy bacteria that are going to take over. What we found by doing this combination is we were able to get almost a 500% increase in that calcium around the two structure. This was the first study that we did and published. Some of these I'll just run through. And the interesting thing about it is it still showed, even though we're only using 15 parts per million, we still showed the same efficacy towards those pathogenic bacteria as chlorhexidine did. Which was significant because we can use basically a non-toxic amount, a non-toxic dose, get a decrease in pathogenic bacteria because of the pH stabilization. But then what happens with daily use is you get a regulatory probiotic environment that's created. This was just a study we did that just showed that it was non-toxic to fibroblasts, which means we can now start to use it and take advantage of some of the other ingredients like the therapeutic dose of xylitol, the nano-silver for wound healing. This was the control that we did that showed that we had upwards of 700% increase in remineralization over fluoride, which was, again, significant. Again, fluoride, and that's the thing, because I know it's a very polarizing topic. I am more from the group that I think that anything, regardless of what it is, what you put in your body, is dose dependent. Fluoride in the water levels that they've had hasn't always been just additive. There's actually been areas where they've had too much fluoride, so the fluoride programs are actually reductive, where they're taking it down, trying to get it at that 0.7 milligrams. We know that fluoride is naturally occurring in things as simple as like ocean water and even breast milk. So we know that toxicity level fluoride is dose dependent. What we have shown and what we've seen in our studies is just that on a day-to-day basis, because it requires an acidic medium, which we don't want because that's destructive in the long run, and because it's not a biofilm penetrant, it's really not doing anything. We really didn't have a use. If it would have been additive, like if we would have shown that by adding fluoride to our nano-silver, produced better results, then we would look at it. It just didn't. And so because it didn't show the efficacy we were looking for, was really the first reason why we just kind of set it aside and started using a bioavailable calcium, which is honestly, in hindsight, the way we look at it, that's what your saliva uses. That's not what most dental products use. Most dental products that incorporate calcium, other than MI paste, which uses a really good source of calcium, a lot of dental products that you see out there, especially the natural ones, will use a calcium carbonate, which again, down to particle size, it's way too big to show any type of integration into the enamel. So again, it's just kind of a fluff product that really doesn't do anything. we do have our own published article in Compendium. This was written up and published. We made the front cover in March of 2020. And all of these are on our website. Like, you can go to our science portion of our website, elementaoralcare.com, and download all of these studies. Okay, so just kind of a quick little recap here. We only need 4 ingredients: nano-silver, calcium acetate, and xylitol. We use a reverse osmosis water as a medium because we've encapsulated nano-silver. Otherwise, you cannot, because of its charge, you cannot mix it with other ingredients. The way we've encapsulated it has allowed us to mix it with other things. So we're able to get a therapeutic dose of xylitol, which does a ton of stuff all in itself. We could have a whole conversation just on xylitol alone. The biggest thing xylitol does is it puts bacteria in a starved state. It starts to pick away. Again, it downregulates pathogenic bacteria, upregulates healthy bacteria, and you start to get a probiotic state. Calcium acetate, again, amazing, bioavailable. If you have a thyroid type issue, you go to the doctor, they're going to give you calcium acetate because it's one of the most bioavailable sources of calcium. It does a ton of other stuff, prevents acid release, neutralizes acid on contact. So if you have people that are struggling or you're out, a quick 30-second rinse or brush with this is going to neutralize that acid attack immediately. This is significant. Let's say you have a patient that's pregnant and they're dealing with that first trimester emesis, right? And a common thing that I've heard a lot of dentists say, that they recommend that their patient immediately rinse their mouth out with water. The problem is you add water, and those strong acids are going to dissociate 100% almost immediately, so it can actually make that acid attack on the teeth worse. You want a neutralizing agent, and nano-silver and calcium will neutralize it immediately. But the other cool thing with calcium acetate, on top of it being bioavailable to the tooth, it's bioavailable to your bone. So we've actually found, and there's a Harvard study that I have as well that's posted on our website that shows that it's osteoinductive. So for bone grafts, we use it as a post-op. We have a surgical grade that we use it for our post-op for bone grafts, periodontal cleanings, implants, extraction sites. Calcium acetate is very, very significant in that osteoinduction and also building the crystalline bridges back. The nice thing is acetate is kind of like a natural preservative. So with nano-silver, we don't have to add any foams or fillers or dyes to the product. We can literally just use the 4 ingredients that we have. Again, here's another study. This is kind of interesting, wrapping things up, that shows that it's nano-silver alone for patients with braces and reducing white spot lesions. And again, this is without a calcium adjunct. This is just nano-silver alone because, again, of its charge, being able to neutralize that stern layer so you're not getting an acid attack, so you're not kicking out those calcium ions that you get around a lot of the bracket sites. Xylitol, we've kind of been over that. We kind of went over the value props for oral surgery and perio. But again, just real quick, the nanoparticle, it's encapsulated, it alkalizes, it stabilizes, but it delivers the calcium to, in a case of an extraction site or a bone graft or an implant, to the extraction site, aids in healing. Again, you're delivering, with each wrench, you're delivering 100 times the amount of bioavailable calcium that your saliva does. So it's awesome for bone formation. Best part is because it's only 4 ingredients, it doesn't stain, it doesn't damage fibroblasts, it actually encourages fibroblast formation and healing. And so it's a great post-op rinse. Some of the other things, I'll just close. Again, one of the most significant studies, and again, it's on our website, is the microbiome reset. Again, you have patients that you probably see every 6 months. They're always coming in with cavities. And again, it's because they're biofilm, and that the negatively charged, that pH negative stern layer. Every 6 months, cavities probably gingivitis, whatever. We did a study, and we were actually approached by a local company that had developed one of the first oral microbiome test kits, and they didn't have a solution. And that's what they said. One of their biggest marketing problems was they had these doctors that were testing and showing pathogenic activity in the oral environment, but they didn't have anything that would actually show a reduction over time. And so they did an in-house study using Elementa, a protocol of just basically brushing and rinsing twice a day was all they did. And what we found was actually significant. In 2 weeks, we had we doubled the amount of healthy bacteria, and it decreased the amount of strep mutans by 50%. They continued it out for a month, and we had a 70 to 99% reduction in pathogenic bacteria. And these were pathogenic bacteria that are linked, they have them linked to like Alzheimer, cardiovascular disease, colorectal cancer. They were pretty significant bacteria. And so what we found is the daily regimen, the daily use of Elementa, the thing that makes it most significant is just that. You can use it on a daily basis, and it's not going to negatively disrupt your biofilm. It's going to encourage a healthy probiotic environment, which is the environment that your enamel needs to hold on to its, not only uptake calcium, but hold on to its calcium. We really feel like we're really the only multifunctional type system that's out there. But anyways, that's kind of, I know we're getting close. I leave some time for questions if you have any, but again, we have all this stuff. If you go to elementaoralcare.com, under the science section, there's also a recap that kind of goes down and explains the science. It also has a lot of our studies that we've published or published studies that we've used for our research as well. That's all I have.
Do you guys have any questions for Matt?
Matt, I have a question.
Yeah.
What is your conversation like with your patients when you're talking to them about this? I mean, you need to obviously have a fairly quick conversation when you educate them. And then, I mean, we have our spill that we give. I'm just interested to hear what you say to your patients.
So give me like an example, like on a specific, if it's someone that, let's say it's recurrent decay, right?
Yeah.
And it's or a mother I mean, probably one of the most common one is, why we just fixed cavities. Why does he have more cavities? Right.
Yeah,
and then it's an easy discussion, because I tell them, I'm like, look, there is a biofilm in the mouth, and that biofilm has a pH that is negatively affecting your child's oral health. It's acid, and it sits on the tooth, and the longer it sits on the tooth, the more damage it does, and you have to neutralize that acid. And the reality is, again, your traditional products are not neutralizing that acid attack. In fact, we've seen on the scale, I mean, I don't want to say they encourage it, but they're definitely not helping it, right? And so I basically have the biofilm discussion with them. I talk to them about the biofilm, how it can be a force for good, but under the right conditions, it can cause damage, and we need to reset it. And honestly, for me, obviously, one of the best things is when I have a patient come back the next 6 months and then they don't have cavities, and they're like, dude, this is the first time in however many years that I've never done it. We've seen like significant changes in our patients' oral health for those who actually implement the Elementa into their daily regimen. It's significant. Even patients that get we've had patients that get tons and tons of tartar, and that's just biological, right? They've got great calcium flow in their saliva. Tartar is way better than plaque. The one thing that you have between tartar and a tooth is called a hydration sheath. So the pH is actually pretty neutral. So that's why rarely around, tartar sites will you actually find decay, because the pH is neutral. Now, the flip side is you're getting inflammation and bone loss, right? So we don't want that either. But what we found with patients, even with heavy tartar, is once they start implementing Elementa, it's not as they don't get the buildup as much. I was one of those. I personally used to get a ton of calculus, and the hygienist would just have to pick and pick and pick and pick. And now it's like what I do get comes off pretty easy. Like it really, most of the discussions like that will lead back to the biofilm and the pH, you'll find.
Awesome. And what are your I was gonna say, what's your protocol with your surgery patients?
So what we have available for post-op is a little 3-ounce. I'll show you real quick. It's a little 3-ounce. This was my and I designed it and packaged it because I kind of did it selfishly. I used to give out the freaking 16-ounce chlorhexidine bottle that the patient would use for like 2 days, and then it was just a waste of money. So this is a 3-ounce. It is dosed. So this cap, if they swish with this cap twice a day, it lasts a week. So if I want them to do it, I usually, for any extraction, bone graft, or implant, I'm a single site. I'm usually only doing 1 week, because then I'm seeing the patient back and I'm removing the suture and a membrane. And so I'll usually give them 1. If it's multi-sites and I feel like they're a little bit more compromised, then I may give them 2 bottles and have them do it for 2 weeks. If they come in with any type of like mouth sore or, some type of tissue insult like that, then I'll go 2 weeks. But it's easily dosed. The surgical rinse actually has about twice the amount of nano-silver. That's why we usually only recommend it for 1 or 2 weeks, only because, again, we know at 15 parts per million, it has probiotic encouragement. When you start to double that, you can get more disruptive to the bacteria. We don't want that. So that's why typically we leave that for a surgical. But the surgical post-op is just that. I give it to them. I'm irrigating with it during the procedure. I rarely do a pre-rinse, but I do have a lot of dentists I know that use it that like to do a pre-rinse as well. But I irrigate with it throughout like say I'm doing an implant, it's my irrigant, and then I give them a bottle to take home and use for their week post-op.
Thank you.
Sorry, I had a question. You may have mentioned this, but do you use this for like patients that have like dry mouth or xerostoma or anything like that? Do you feel like that helps out with?
Absolutely. Dry mouth is frustrating. It's probably one of the most disruptive things, right, for oral health. Yeah. And the problem is, again, when we go back to these the previous slides that we talked about, the reason why it's so disruptive is right down here to the ZPC again. You have no buffer. They have no capacity to buffer that acid. The interesting thing about, so enamel will demineralize at 5.5. Root structure, dentin will demineralize, and the cement will demineralize at 6.5. Doesn't take much. There's bottled water that's 6.5. So you can get demineralization of root structure with bottled water. So these patients have no capacity to do that. The one thing that xylitol is, and that's really the only thing in this realm that we have, is xylitol, because it does that. It helps buffer.
That's what I do. I'd tell them to do water in xylitol at night, put some in there, and just rinse with it when you wake up, because who knows what they're using. But
that's really all they can do. The Elementa adds the additional calcium. You get an additional, an immediate buffering from it, where which adds, it's just an added benefit. The nano-silver as well, you get at least, you start to get the delivery from it through the harsh biofilm. So there's a mechanism to it that would help it be better than just xylitol alone. But xylitol also, what it does, because it's a sweetener, it kind of tricks the body, and so that's why they say it's almost like they're eating. And so it can help have some organic salivary encouragement. But really, yeah, so for dry mouth, that's what we tell our patients. We're like, you basically just use it as often as you need to.
Okay.
That's where mints, xylitol mints and gums are really good for patients. A gum and a mint will kind of do the same thing. It puts the body mind connection into like, oh, I'm feeding, and you can get some organic salivary flow encouragement from it. But a lot of the people who say, oh, xylitol stimulates salivary flow, it's very roundabout. You know, you're not going to get huge salivary flow increase. You can just try and prevent the damage that it's doing. So it sounds like you're doing everything that needs to be done.
I like anything that I can throw at someone that I have a patient in mind that just every time they come in, and it's just dry mouth. So it's nice to have something else I can throw at that.
Yeah. And there's a, again, on our website under that science section, there's a protocol sheet that you can download that has the protocols for all the different conditions like that, what we recommend. So.
Well,
right.
I can tell you guys the reason so the reason I asked Matt to come and do this is because we really believe in Elementa in our office. This is something that, again, I'm not paid by Elementa. You know, it's just the only thing that Matt pays me with is hanging out with me. So that's and it's a high cost for him, but you know,
yeah,
we really do believe in this product because we've used it. We have patients that come in and like they've had, I don't need to get into the details, but basically Elementa went through some business changes over the last couple of years, and there's been a couple times where we couldn't get a certain flavor or whatever due to some back ordering, and patients were flipping out. They were like, well, I need that though. Like they were having conniptions in our office because they've really become reliant on it. And it's something that I personally use every day. And if you ever want to just try it out and see that the science is legit, get some for yourself, try it out, and you'll notice. For me, it takes about a week for me to really start to notice it, but based on the science, that makes sense. And then once you go off it, you'll notice it as well. But it is something that like all of our patients, we want all of our patients on it. We do use the surgical rinse after all of our surgeries. And there's a lot of really cool science that's backing all this. I think Matt's kind of scratched the surface here on the basic stuff, but and also Matt, I'm assuming that you'd be available to answer any questions offline too if they want.
Yeah, absolutely. We've got, again, and any topic you want to delve into more. I mean, again, I kind of gave you just a brief overview today, but like even that, if you want to go into, I've got full write-ups on just our nano-silver or just the stern layer or, you know, whatever. I've got a bunch of different, any topic you want to delve into, feel free. And again, the biggest thing, like I said, it's been an educational process for us. So like Dan, I'm not even saying, you know, buy my product, but get on our website and start going through the science, because it literally, you'll feel empowered as a dentist, especially as an educator to your patients, 100%. It going down that road and starting to learn the science behind it has been so empowering for me.
Yeah, this has been transformative for me as well, because I approach healing my patients differently than I did before I understood. And you know what's funny is that right after Matt started talking to me about all of this science, I started to delve into inflammation. And we had a guy who we're friends with through Elevation Association that he got really sick and did his own research and started diving into you know, the acidic, what acids are doing to our bodies and through inflammation. And so that really cracked the book open for me to start learning about inflammation and just how dangerous acids are and what they do, not just to the oral environment, but to the entire body. And it's a pretty fascinating thing when you start going down that rabbit hole. I'm not recommending that you do this, but we do have a friend also that since he started carrying the Elementa, when he gets heartburn, he drinks a little bit of it. And I know, Matt, that's not on label, that's an off label thing, but he drinks a little bit of it and it cures it. So there is some
again, it's a neutralizing agent, and with the calcium and the nano-silver and the xylitol, it's almost an immediate neutralization. So I would be lying if I didn't say I've done the same thing.
Well, cool. Is there any other questions you guys have? Have any of you guys come across Elementa Silver before? Okay, Mackenzie, not.
No, I'm
no.
not familiar with it. No.
Mike, have you seen it before?
I have not.
I don't know if Jeremy, have you come across it?
No, I haven't either.
So this is cool. I'm glad this is new to all of you. Highly recommend that you check out their website. Again, I've got no skin in this game at all, other than I believe in it. And it's something that we've come to rely on in our office. So
we're actually, I will say, we're just kind of in discussions right now with a larger dental materials company to, the silver diamine fluoride has kind of been a big thing. Does anybody use silver diamine fluoride?
Yeah.
The SDF?
Yeah.
So yeah, we're actually talking with the company right now to basically use our silver. The problem they've been having with some of these silver fluorides is, again, the stability. And so we're actually talking with the company to use our silver in their silver diamine fluoride product. But the other thing that's super interesting is because of the fluoride discussion, we've actually tested instead of silver fluoride, silver calcium, and it actually outperformed the silver fluoride again. Again, not surprisingly to us, because your tooth is a calcium phosphate bridge, but nonetheless, we're kind of in the beginning engineering stages of creating kind of like a competition product to silver fluoride. So,
well, for those of you that are coming to the Elevation Association Outfitter Masterclass, Leadership Masterclass, Matt's going to be there May 30th and 31st. So Matt will be there. Definitely pick his brain while you're up here. Email him. You could call him. He's very available. Well, his daughter's getting married this weekend, so probably not this weekend, but after that, right, Matt?
Yeah, that's right.
Well, cool. Well, Matt, really appreciate you jumping on, and this has been awesome. So mega thanks. It's good to see all you guys. Any questions about anything else regarding the mastermind or anything like that?
I was going to say, appreciate it, Matt. And then Dan, can you put a link to his products?
Totally. Yep.
Yeah, throw my email in there too, Dan, just so that way, if you guys have any questions. We do have 4 dental offices, and it's on the webpage too. You can go into professional, and in essence, you can sign up as a wholesaler. So then you get discounts, basically the wholesale rates, which is 50, 60% cheaper than what the web rates are, just by acting as a professional, buying in bulk. And so I would recommend, if you do anything like that, definitely do that to get the cost savings, than just buying it directly from the website. But yeah, any questions, just send me an email.
Well, not because I think these guys are going to want to try this, Matt. And when they see the crust going around the lid, can you just explain that really fast so they don't freak out when patients are like, it's getting all crusty everywhere?
Yeah. So it like anything else, right? Like if you don't keep the top of it clean, Dan's not very clean. I wiped my tip. But no, yeah. Calcium, xylitol, especially the calcium acetate is a strong crystalline bridge formator. So you will get, if you leave the residue on, you can see that it'll start to get crystallization around the lid top.
Cool.
So-
Awesome. All right, fellas. Good to see everybody.
Thank y'all.
Yeah.
If you guys have any
you.
questions that you have for us, let me know as well. Otherwise, we'll see you guys next month.
Sounds
Good.
good.
Thanks, guys.
Appreciate it.
Thanks,
Thanks,
guys.
Dan.
Bye.
See you guys.
Cheers.
See ya.
See you guys.